The crucible of innovation. The battlefield has always been humanity's most brutal teacher. Throughout history, wars have driven medical innovation forward at an accelerated pace, forcing physicians, surgeons, and field medics to develop new techniques under the most extreme circumstances imaginable. However, no conflict in human history transformed trauma care as profoundly as World War II. Between 1939 and 1945, the convergence of unprecedented casualties, technological advancement, and dedicated medical personnel created a perfect storm of innovation that would forever change how we treat traumatic injuries. When the first shots of World War II were fired in September 1939, military medicine was still recovering from the lessons of the Great War. The trenches of World War I had taught doctors about gas gangrene, the importance of wound debridement, and the devastating effects of artillery on the human body. Yet, despite these advances, the survival rate for severely wounded soldiers remained disturbingly low. Infection claimed countless lives, shock remained poorly understood, and blood loss often proved fatal, even for soldiers who reached medical facilities alive. What emerged from the chaos and carnage of World War II was nothing short of a medical revolution. The 6 years of global conflict saw the development of mobile surgical units, the widespread use of antibiotics, revolutionary blood transfusion protocols, and innovative triage systems that prioritized treatment based on survivability rather than rank or severity alone. These innovations would not only save hundreds of thousands of lives during the war, but would also lay the foundation for modern emergency medicine, transforming civilian trauma care in ways that continue to benefit humanity today. The story of how WT2 medics revolutionized battlefield trauma care is one of courage, ingenuity, and relentless dedication to preserving human life under the most adverse conditions imaginable. It is a story of young men and women, many barely out of their teens, who carried medical bags instead of rifles into the heart of battle. It is a story of brilliant physicians who transformed battlefield observations into life-saving protocols. And it is a story of how the worst of human conflict, paradoxically, produced some of the greatest advances in medical science. The state of military medicine before World War II. To appreciate the revolutionary changes that occurred during World War II, we must first understand the state of military medicine as it existed in the late 1930s. Despite the lessons learned during World War I, military medical services across the globe remained woefully unprepared for the scale and nature of combat that would characterize the Second World War. The interwar period had seen some important developments in military medicine. The British, French, and German armies had refined their casualty evacuation systems, recognizing that rapid transport from the front lines to surgical facilities significantly improved survival rates. The concept of the chain of evacuation, moving wounded soldiers through progressively more sophisticated levels of medical care, had been established. However, the implementation of this system remained inconsistent, and many nations entered the war with outdated equipment and insufficient medical personnel. Medical education in the 1930s had not yet embraced the concept of emergency medicine as a distinct specialty. Surgeons trained primarily in elective procedures performed in well-equipped hospitals with adequate time for preparation and post-operative care. The skills required for rapid surgical intervention on a soldier with multiple traumatic injuries performed in a tent while artillery shells exploded nearby were not part of standard medical curriculum. Most physicians who would serve in World War II had never seen a gunshot wound, treated severe burns, or managed traumatic amputations before entering military service. The treatment of shock, a condition that would prove to be one of the leading causes of battlefield death, remained poorly understood. Medical doctrine of the era recognized that wounded soldiers often died not from their injuries directly, but from a mysterious condition characterized by falling blood pressure, rapid pulse, pale skin, and eventual cardiovascular collapse. Various theories attempted to explain shock, including the acapnea theory, which suggested that excessive loss of carbon dioxide from hyperventilation caused the condition, and the toxemia theory, which blamed circulating toxins released from damaged tissue. Without a clear understanding of shock's true cause, primarily hemorrhage, fluid loss, and inadequate tissue perfusion, treatment protocols were often ineffective or even counterproductive. Some medical officers administered stimulants like caffeine or strychnine, believing that shock resulted from nervous system depression. Others recommended limiting fluid administration, fearing that increasing blood volume might restart hemorrhaging from partially clotted wounds. These misguided approaches cost countless lives in the early months of the war. Blood transfusion technology existed but remained in its infancy. Karl Landsteiner's discovery of blood types in 1901 had made transfusions possible, but the procedures remained complex and risky. Blood could not be stored for extended periods, requiring direct donor-to-recipient transfusions or the use of fresh blood collected shortly before administration. The logistics of maintaining adequate blood supplies near combat zones proved nearly impossible with the technology available in 1939. Infection control presented another major challenge. Although Alexander Fleming had discovered penicillin in 1928, the antibiotic had not been mass-produced or widely distributed by the time war broke out. Sulfa drugs represented the primary anti-infection treatment available to military physicians, but their effectiveness remained limited. Gas gangrene, tetanus, and other bacterial infections continued to kill soldiers who survived their initial injuries just as they had in previous conflicts. Surgical techniques had advanced somewhat since World War I, but the speed and efficiency required for battlefield surgery remained elusive. The principle of wound debridement, removing devitalized tissue and foreign material to prevent infection, had been established by French surgeons during the Great War. However, the conservative approach to surgery that dominated civilian medicine in the interwar years had not prepared physicians for the aggressive interventions that battlefield trauma would require. Perhaps most significantly, the organizational structure of military medical services had not kept pace with the changing nature of warfare. World War I had been primarily a static conflict, with relatively predictable casualty patterns and fixed medical installations behind established frontlines. World War II would prove to be a war of movement, with rapid advances, sudden retreats, and fluid battle lines that would demand unprecedented flexibility from medical units. The various branches of military medicine, the medical corps, the nurses, the medics, and corpsmen, had not yet developed the integrated systems that would prove essential to battlefield trauma care. Communication between echelons of care remained poor, with little standardization of treatment protocols or documentation of injuries. A soldier wounded in the morning might receive contradictory treatments from 3 different medical personnel by afternoon, with no coordinated plan for his care. Transportation of wounded soldiers relied primarily on ambulances designed in the previous war, many of them uncomfortable, poorly equipped, and lacking the medical supplies necessary for treating patients during transport. The concept of a mobile intensive care unit, a vehicle staffed with trained medical personnel and equipped to provide advanced life support during evacuation, had not yet been developed. Training of combat medics and corpsmen varied widely between nations and even between different units within the same army. Some medics received months of comprehensive instruction in anatomy, physiology, and emergency treatment. Others were given only a few weeks of basic training before being sent to the front lines with a medical bag and a prayer. The heroic image of the combat medic that would emerge during World War II, the brave individual who rushed into gunfire to save his comrades, existed more in aspiration than in systematic military doctrine.
The early war years, learning through catastrophe. The opening campaigns of World War II quickly revealed the inadequacy of existing military medical systems. Germany's blitzkrieg tactics in Poland, France, and the Low Countries created casualty patterns that overwhelmed traditional medical evacuation systems. The speed of German advances often left medical units behind enemy lines or forced hasty evacuations that disrupted continuity of care. The Battle of France in May and June 1940 proved particularly instructive and devastating. British, French, and Belgian forces suffered over 360,000 casualties in 6 weeks of fighting. Medical services struggled to keep pace with the rapid German advance, and many wounded soldiers died not from their injuries, but from the chaos of retreat. Field hospitals were abandoned, surgical units were captured, and thousands of wounded men were left behind during the evacuation at Dunkirk. These early disasters forced military medical planners to completely rethink their approach to battlefield trauma care. It became clear that the static medical infrastructure of World War I was obsolete. Medical units would need to be mobile, self-sufficient, and capable of providing advanced surgical care close to the front lines. The concept of the Mobile Army Surgical Hospital, or MASH, though it would not be formally established until the Korean War, had its genesis in the lessons learned during these early World War II campaigns. The importance of rapid evacuation became painfully apparent. Studies emerging from the early war years showed that a soldier's chance of survival decreased dramatically with each hour of delay between injury and definitive surgical treatment. The golden hour, the critical first 60 minutes after trauma, when intervention is most effective, became a guiding principle of battlefield medicine, though that specific term would not be coined until decades later. British medical officers, analyzing casualties from the French campaign and the early North African operations, noticed a disturbing pattern. Many soldiers arrived at surgical facilities alive, but died on the operating table or shortly thereafter from what appeared to be shock and cardiovascular collapse. These men had survived hours of transport, only to succumb once definitive treatment began. This paradox demanded explanation. The breakthrough came from understanding that shock resulted primarily from fluid loss, not just blood, but also plasma and other body fluids. When soldiers lay wounded on the battlefield for hours, their bodies attempted to compensate for blood loss by shifting fluid from cells and tissues into the bloodstream to maintain blood pressure. By the time they reached surgery, they were profoundly dehydrated and depleted of the volume necessary to maintain circulation. This realization led to a fundamental shift in the approach to trauma care. Treatment of shock through aggressive fluid resuscitation became the first priority even before surgery to repair injuries. The principle of resuscitation before operation saved countless lives and represented one of the early major innovations of World War II battlefield medicine. The Battle of Britain in 1940 contributed its own lessons to the evolution of trauma care. The aerial bombardment of British cities created a new category of casualties: civilian victims of blast injuries, crush wounds from collapsed buildings, and severe burns from incendiary devices. British physicians found themselves treating injury patterns they had never encountered before, learning on the fly as German bombers returned night after night. Dr. Archibald McGindow, a New Zealand-born plastic surgeon working at Queen Victoria Hospital in East Grinstead, began treating Royal Air Force pilots with severe facial burns and disfigurement. His work would revolutionize burn treatment and plastic surgery, establishing principles of wound care, skin grafting, and psychological support that remain foundational to burn medicine today. McIndow's Guinea Pig Club, his affectionate name for the hundreds of severely burned airmen he treated, became pioneers in reconstructive surgery and rehabilitation. The early campaigns in North Africa, beginning in 1940, presented entirely different medical challenges. The harsh desert environment, with its extremes of temperature, water scarcity, and omnipresent sand and dust, created conditions that exacerbated wound infections and complicated surgical procedures. Medical units operating in the Western Desert learned to adapt their techniques to these harsh conditions, developing new protocols for wound cleaning, infection prevention, and hydration management. The seesaw nature of the North African campaign, with territories changing hands multiple times between British and Axis forces, meant that medical units frequently found themselves treating both friendly and enemy wounded. This led to innovations in triage and mass casualty management, as overwhelmed surgeons developed systems for prioritizing treatment based on injury severity and likelihood of survival, rather than nationality. German military medicine was also evolving rapidly during these early years.
The Wehrmacht's medical service had entered the war with some advantages, including more extensive use of sulfa drugs and a well-organized evacuation chain. German field hospitals were generally well-equipped and staffed by experienced surgeons. However, the German medical service suffered from the same fundamental limitations as other combatants: inadequate understanding of shock, limited antibiotics, and blood supply problems. One area where German military medicine excelled was in the organization of their casualty collection system. The Germans used a tiered approach with clearly defined roles. Sanitär, or medics, provided immediate first aid. Truppenverbandplatz, battalion aid stations, offered initial treatment, and Hauptverbandplatz, main dressing stations, provided more advanced care before evacuation to field hospitals. This systematic approach influenced Allied medical organization as the war progressed. The Soviet experience in the early war years was characterized by catastrophic casualties and desperate improvisation. The German invasion of June 1941 inflicted millions of casualties on the Soviet forces, overwhelming medical services that were already inadequate. Soviet combat medicine in 1941 and 1942 was often rudimentary, with severe shortages of supplies, trained personnel, and even basic medical equipment. However, necessity drove innovation. Soviet physicians developed techniques for operating in extreme cold, treating frostbite, and managing casualties in situations where resources were nearly non-existent. Soviet female combat medics, who made up a significant portion of frontline medical personnel, demonstrated extraordinary courage and effectiveness. The image of Soviet women carrying wounded soldiers from battlefields under fire became one of the war's most enduring symbols of medical heroism.
The Blood Revolution, from donor to battlefield. Perhaps no single innovation saved more lives during World War II than the development of effective blood banking and transfusion systems. At the war's outset, blood transfusion was an inefficient, risky procedure that could rarely be performed near the front lines. By war's end, blood transfusion had become routine, with sophisticated collection, storage, and distribution systems delivering life-saving blood products to wounded soldiers within hours of injury. The story of the Blood Revolution begins with Dr. Charles Drew, an African-American physician, whose research on blood plasma and blood banking would prove crucial to Allied medical efforts. Working at Columbia University in the late 1930s, Drew had investigated methods for separating, processing, and storing blood plasma, the liquid component of blood minus the red blood cells. His research revealed that plasma could be dried, stored for extended periods, and reconstituted when needed, all without refrigeration. This discovery had enormous implications for military medicine. While whole blood required refrigeration and could be stored for only a few weeks, dried plasma could be packaged, shipped to combat zones, and stored under field conditions almost indefinitely. Plasma contained the clotting factors, proteins, and fluid volume needed to treat shock, even if it lacked the oxygen-carrying capacity of whole blood. When Britain came under aerial bombardment in 1940, Dr. Drew was asked to establish a pilot program called Blood for Britain, collecting and processing blood plasma in the United States for shipment across the Atlantic. The program was a resounding success, establishing protocols for mass blood collection that would later be expanded to support American military operations. In early 1941, Drew was appointed director of the American Red Cross Blood Bank and assistant director of blood procurement for the National Research Council. Under his leadership, the first major blood banking system was established, with collection centers in cities across the United States. Drew's work standardized procedures for blood typing, testing, processing, and storage that ensured the safety and effectiveness of blood products used in transfusions. The development of blood substitutes and extenders complemented the advances in blood banking. Plasma proved so effective in treating shock that it became standard issue for combat medics. Small packages of dried plasma could be easily carried, quickly reconstituted with sterile water, and administered intravenously by personnel with relatively minimal training. For the first time in military history, life-saving fluid resuscitation could begin on the battlefield itself, not hours later at a surgical facility. The logistics of the blood supply chain became increasingly sophisticated as the war progressed.
Blood collection centers in the United States collected whole blood from civilian donors, processed it into plasma or packed red blood cells, and shipped it overseas in refrigerated containers. By 1944, the American military was transfusing over 500,000 units of blood annually, a logistical achievement that would have been unimaginable just a few years earlier. The British developed parallel blood banking systems, with the Army Blood Supply Depot coordinating collection, processing, and distribution throughout the European and Mediterranean theaters. British mobile transfusion units could deploy close to front lines, equipped with refrigeration units powered by generators, allowing for the use of whole blood when plasma alone was insufficient. The impact of readily available blood products on survival rates cannot be overstated. Studies from the North African campaign showed that soldiers who received plasma transfusions within the first few hours after injury had survival rates 40 to 50% higher than those treated without early fluid resuscitation. Even severely wounded soldiers with multiple injuries had a fighting chance if shock could be prevented or reversed through timely blood product administration. The science of blood transfusion advanced rapidly during the war years. Physicians learned to recognize and treat transfusion reactions, developed protocols for massive transfusion in cases of severe hemorrhage, and established safe blood storage practices. The use of anticoagulants like sodium citrate allowed blood to be stored without clotting, extending its shelf life from days to weeks. One of the most significant refinements was the development of different blood components for different purposes. Whole blood was ideal for soldiers with severe hemorrhage who needed both oxygen carrying capacity and volume replacement. Plasma or plasma substitutes like albumin were effective for treating shock from burns or non-hemorrhagic trauma. Packed red blood cells could provide maximum oxygen carrying capacity with minimal volume, useful for certain types of injuries. The concept of the walking blood bank emerged in situations where stored blood was unavailable. Medical units would identify universal donors, type O negative, who could be called upon to donate blood for emergency transfusions. This practice, while not ideal, saved lives in remote theaters where supply chains had broken down or casualties exceeded available blood supplies. Combat medics and corpsmen became proficient in establishing intravenous access and administering fluids and plasma under battlefield conditions. Special training programs taught these young men to recognize the signs of shock, calculate appropriate fluid volumes, monitor vital signs during resuscitation, and document treatments. The modern concept of the paramedic, a non-physician medical provider capable of performing advanced life support procedures, emerged from these World War II combat medics. The blood revolution extended beyond immediate trauma care to influence surgical practice as well. Surgeons gained confidence in attempting complex operations that would have been too risky before reliable blood transfusion became available. Operations for severe abdominal injuries, complex fractures, and traumatic amputations became more successful as surgeons could replace blood loss during lengthy procedures. Interestingly, the blood supply system highlighted racial inequalities within the U.S. military. Despite Dr. Charles Drew's pioneering work, the American Red Cross initially segregated blood donations by race, refusing to mix blood from African American and white donors. Drew himself spoke out against this unscientific practice, noting that blood types were the only relevant factor in transfusion compatibility. The policy was eventually modified, though blood continued to be labeled by donor race until after the war.
Penicillin, the war-winning drug. If blood transfusion provided the volume needed to keep wounded soldiers alive, antibiotics provided the defense against the microscopic enemies that had killed millions of wounded soldiers throughout history. The mass production and distribution of penicillin during World War II represented one of the war's most significant medical achievements, transforming infection from a near-certain death sentence into a treatable condition. Alexander Fleming's 1928 discovery of penicillin had remained largely a laboratory curiosity for over a decade. The substance was difficult to produce in quantity, unstable, and challenging to purify. By the late 1930s, penicillin seemed destined to remain a fascinating scientific observation with little practical application. World War II changed everything.
In 1939, Australian pathologist Howard Florey and German refugee biochemist Ernst Boris Chain, working at Oxford University, began investigating penicillin's potential as an antibacterial agent. Their research demonstrated that penicillin could cure bacterial infections in laboratory animals with remarkable effectiveness and minimal toxicity. The challenge was producing enough of the substance to test in human patients. Early human trials in 1941 showed dramatic results. Patients dying of bacterial infections recovered completely after penicillin treatment. However, producing enough penicillin for even a single patient required enormous effort. The researchers famously recycled penicillin from patients' urine to stretch their limited supplies during these early trials. Recognizing penicillin's potential military importance, British officials approached the United States for help with mass production. American pharmaceutical companies, with their greater manufacturing capacity and resources, accepted the challenge. A massive research and development effort ensued, involving government agencies, universities, and pharmaceutical manufacturers in a coordinated push to scale up penicillin production. The technical challenges were formidable. Penicillin-producing mold grew slowly and produced only tiny amounts of the active substance. Researchers tested thousands of mold strains, seeking more productive varieties. Scientists experimented with different culture media, growth conditions, and extraction methods. Engineers designed specialized fermentation vessels and purification systems. Breakthroughs came from unexpected places. A productive penicillin-producing mold strain was discovered on a moldy cantaloupe at a Peoria, Illinois market. The use of corn steep liquor as a culture medium dramatically increased yields. Deep tank fermentation methods adapted from the brewing industry allowed for large-scale production. By 1942, enough penicillin was being produced to treat limited numbers of military casualties. The first significant military use of penicillin came during the North African Campaign in 1943. Medical officers documented remarkable results. Soldiers with infected wounds that would previously have required amputation retained their limbs after penicillin treatment. Pneumonia, which had killed many wounded soldiers weakened by injury and surgery, responded dramatically to the new antibiotic. Gas gangrene, the dreaded infection that had claimed countless lives in World War I, could now be treated effectively when caught early. Success stories spread rapidly through military medical channels. A soldier shot through the abdomen and expected to die from peritonitis survived after penicillin treatment. A pilot with severe facial wounds contaminated with dirt and debris healed without infection. A Marine with a shattered femur avoided the amputation that would have been routine just months earlier. Each success fueled demand for more of the wonder drug. Production scaled up at breathtaking speed. By D-Day in June 1944, Allied forces had sufficient penicillin to treat all severe casualties. Monthly production reached 650 billion units by war's end, enough to treat over 7 million patients. The pharmaceutical industry's response to the penicillin challenge demonstrated what coordinated industrial effort could achieve when motivated by military necessity. The logistics of delivering penicillin to wounded soldiers were as important as production itself. The antibiotic required refrigeration and had a limited shelf life. Military medical supply chains had to be reconfigured to maintain cold storage from manufacturing plants through multiple transportation stages to field hospitals and even frontline aid stations. Special packaging protected penicillin from heat, moisture, and physical damage during shipment. Protocols for penicillin administration evolved through battlefield experience. Initially, physicians reserved the precious antibiotic for the most severe infections. As supplies increased, prophylactic use became standard for contaminated wounds, even before infection developed. Research established optimal dosing schedules with frequent injections needed to maintain therapeutic blood levels. Combat medics couldn't administer penicillin in the field. That required physicians or nurses at aid stations and field hospitals. However, medics learned to carefully document wound contamination and suspected infection so that appropriate antibiotic treatment could begin immediately upon evacuation. This communication between echelons of care proved crucial to preventing serious infections. The impact of antibiotics on wartime mortality was dramatic. In World War I, infection killed thousands of wounded soldiers, even those with relatively minor injuries. The case fatality rate for soldiers with abdominal wounds approached 70%, largely due to peritonitis. By late World War II, with penicillin widely available, the case fatality rate for similar injuries had dropped below 25%. Pneumonia, which killed 18% of wounded soldiers in World War I, killed less than 1% in World War II after penicillin became available. Penicillin's success against bacterial infections was not universal. The antibiotic proved ineffective against some bacterial species and useless against viruses and fungi. Medical officers documented these limitations and sought alternative treatments. This led to the identification and development of other antibiotics, including streptomycin and bacitracin, expanding the arsenal against infection. The widespread use of penicillin during World War II also provided the first evidence of antibiotic resistance, though this would not be fully understood until after the war. Some bacterial strains survived penicillin treatment, demonstrating that evolution could produce resistance even to powerful antibiotics. This observation would have profound implications for medicine in the decades to come. Beyond its direct medical impact, penicillin's success transformed pharmaceutical development. The model of government-funded research collaboration with private industry established during wartime continued afterward, accelerating the development of new drugs. The golden age of antibiotic discovery in the 1950s and 1960s owed much to techniques and expertise developed during the wartime push to mass-produce penicillin.
Mobile surgical units, bringing the hospital to the front. One of World War II's most significant innovations in battlefield trauma care was the development of mobile surgical units capable of performing complex operations close to the front lines. These units represented a fundamental shift in military medical philosophy, recognizing that survival often depended on rapid access to surgical intervention rather than lengthy evacuation to distant hospitals. The concept evolved differently across various theaters and armies, but the underlying principle remained constant. Surgical capability needed to move forward with advancing armies, rather than waiting safely in the rear. The British developed forward surgical units, FSUs. The Americans created auxiliary surgical groups, ASGs, and later mobile army surgical hospitals, or MASH units, for the Korean War. The Germans refined their Feld Lazarett system. These mobile surgical units were essentially hospitals in miniature, designed to be packed into trucks, moved to a new location, and operational within hours. A typical unit included several large tents for triage, preoperative preparation, operating rooms, and post-operative recovery. Supporting tents housed sterilization equipment, supply storage, laboratories, and staff quarters. Everything was designed for rapid deployment and mobility. The staffing of mobile surgical units represented a careful balance between capability and portability. A typical unit included several surgeons with different specialties, orthopedic, abdominal, and general surgery being most critical. Anesthesiologists or nurse anesthetists provided crucial expertise, as battlefield surgery required reliable anesthesia under challenging conditions. Operating room nurses, surgical technicians, and support personnel completed the medical team. The equipment carried by mobile surgical units had to be robust, portable, and functional under field conditions. Operating tables designed for easy assembly and disassembly replaced fixed hospital tables. Portable lighting systems, often powered by generators, illuminated surgical fields. Sterilization equipment, including autoclave units that could run on various fuels, ensured that instruments remained clean despite austere conditions. Suction devices, blood pressure monitors, and other essential equipment were ruggedized for field use. Anesthesia in mobile surgical units presented unique challenges. The flammable nature of ether and other common anesthetic agents created fire risks in tent operating rooms lit by lanterns or open flames in cold weather. Spinal anesthesia became popular for lower extremity surgeries, avoiding the risks and equipment needs of general anesthesia. When general anesthesia was necessary, careful protocols minimized fire hazards. The surgical procedures performed in mobile units evolved throughout the war. Initially, surgeons attempted only the most essential life-saving operations, controlling hemorrhage, removing contaminated tissue, and treating abdominal injuries that would be fatal without immediate intervention. Conservative approaches dominated, with surgeons doing the minimum necessary to stabilize patients for evacuation to rear echelon hospitals where definitive repairs could be completed. Experience proved this conservative approach sometimes caused more harm than good. Soldiers evacuated with temporary treatments often developed complications during transport or required multiple operations to complete repairs that could have been done initially. Gradually, surgeons in mobile units began performing more definitive procedures, recognizing that doing the job right the first time often served patients better than staging operations across multiple facilities. The treatment of extremity injuries exemplified this evolution. Early war doctrine called for simple wound cleaning and splinting, with definitive orthopedic surgery delayed until evacuation to base hospitals. This approach resulted in poor outcomes. Bones healed improperly, infections developed in inadequately debrided wounds, and many soldiers endured multiple operations. Mobile surgical units began performing primary wound closure, internal fixation of fractures, and vascular repairs that significantly improved outcomes. Abdominal surgery in mobile units became increasingly sophisticated. Surgeons learned to repair intestinal perforations, remove damaged sections of bowel, and reconstruct urinary tract injuries under field conditions. The availability of blood transfusion and antibiotics made these complex procedures survivable even in austere environments. Soldiers with abdominal gunshot wounds, nearly always fatal in previous wars, now had reasonable chances of survival if they reached surgery quickly. The treatment of head and chest injuries presented special challenges. Neurosurgery and thoracic surgery required specialized equipment and expertise often unavailable in mobile units. However, basic procedures, removing accessible skull fragments and brain debris, placing chest tubes to re-expand collapsed lungs, and controlling hemorrhage from chest wounds could be performed by general surgeons and saved many lives. The speed of surgical decision-making in mobile units demanded rapid assessment and decisive action. Triage officers evaluated incoming casualties, determining who needed immediate surgery, who could wait, and who was beyond help. These agonizing decisions were guided by brutal pragmatism. Save the maximum number of lives possible with available resources. A soldier with devastating injuries who might survive after days of intensive care at a modern hospital would be triaged as expectant if treating him would consume resources needed for 3 soldiers with better survival chances. The physical environment of mobile surgical units tested the endurance of medical staff. Operating tents sweltered in summer heat or froze in winter cold. Surgeons performed delicate operations while standing on muddy ground, often for 12 to 20 hours straight when casualties flooded in. The constant threat of artillery fire or air attack added psychological stress to physical exhaustion. Yet these medical teams maintained remarkable surgical success rates under conditions that would seem impossible to modern physicians, accustomed to climate-controlled operating rooms with abundant support staff. Communication and coordination between mobile surgical units and other medical echelons proved crucial. Forward aid stations needed to know each unit's location and capabilities to direct casualties appropriately. Mobile units needed information about incoming casualties, numbers, injury types, and estimated arrival times to prepare adequately. Ambulance drivers needed clear directions to find units that might have moved since their last trip. Radio communication, messenger services, and eventually telephone lines kept this complex system functioning. The mobility of these units came at a cost: instability in patient care. When armies advanced or retreated rapidly, surgical units had to move, disrupting treatment of patients not yet stable for evacuation. The decision to move or stay put while casualties still required care created agonizing dilemmas. Sometimes units split, with some staff remaining to care for patients while others moved forward with combat units. Other times, patients had to be evacuated prematurely, risking their lives because military necessity demanded the surgical team move. Several campaigns highlighted the value of mobile surgical units. During the Italian campaign, with its mountainous terrain and slow advance, mobile units proved essential. Evacuation from mountain positions was slow and dangerous, making rapid access to surgery critical. During the rapid advance across France after D-Day, mobile units leapfrogged forward, maintaining surgical capability close behind advancing armor. In the Pacific, mobile surgical units operated under jungle conditions, dealing with tropical diseases alongside combat injuries. The success of mobile surgical units influenced military medical organization for decades. The MASH units of the Korean War directly descended from World War II auxiliary surgical groups. Modern Role 2 and Role 3 medical facilities deployed in Iraq and Afghanistan embodied the same principles: bring surgical capability forward to minimize the time between injury and definitive care. Civilian trauma systems with trauma surgeons available 24/7 in designated trauma centers reflect military lessons about the importance of rapid access to surgical expertise.
The medic and corpsman, heroes without weapons. No account of World War II battlefield medicine would be complete without acknowledging the combat medics and Navy corpsmen who provided frontline care under fire. These young men, most in their late teens or early 20s, carried no weapons, yet routinely exposed themselves to enemy fire to reach wounded comrades. Their courage, skill, and dedication saved countless lives and created an enduring image of selfless heroism. The training of combat medics varied among Allied nations, but generally included several months of intensive medical instruction followed by field exercises. American medics attended medical training programs where they learned anatomy, physiology, first aid procedures, bandaging techniques, and the use of medical supplies from their aid bags. They practiced giving injections, applying tourniquets, splinting fractures, and treating shock. Physical conditioning prepared them for the demands of carrying heavy medical supplies while keeping pace with infantry units. German sanitators received similar training, often with greater emphasis on treating specific battlefield injuries. Japanese medical personnel training was more variable, with some receiving extensive education while others were given only rudimentary instruction. Soviet medical units relied heavily on female medics, many of whom had nursing training before entering military service. The equipment carried by combat medics was carefully designed for battlefield utility. The iconic medic's aid bag contained bandages of various sizes, tourniquets, morphine syrettes for pain relief, sulfanilamide powder for wound infection prevention, iodine for sterilization, scissors and hemostats, splinting materials, and later in the war, packages of dried plasma. The bag and its contents weighed 15 to 20 pounds, carried in addition to the medic's personal gear. The first aid rendered by medics on the battlefield followed established protocols, but required constant adaptation to circumstances. Upon reaching a wounded soldier, the medic's first priority was controlling hemorrhage, applying pressure, bandages, or tourniquets as the situation demanded. Airway management came next, ensuring the wounded man could breathe by clearing obstructions or positioning him properly. Treatment for shock followed, with the medic covering the casualty with blankets, elevating his legs if possible, and reassuring him while preparing for evacuation. Pain management was a critical medic responsibility. The morphine syrette, a small disposable injector containing a standard dose of morphine, allowed medics to provide powerful pain relief quickly.
However, morphine use required judgment. Too much could depress respiration in patients with chest injuries, and masking pain might obscure symptoms that surgeons needed to assess. Medics were trained to mark an M on the forehead of soldiers who received morphine, preventing accidental overdose if multiple medical personnel treated the same casualty. The physical courage required of combat medics cannot be overstated. While Geneva Convention protocols theoretically protected medical personnel from deliberate targeting, bullets and shell fragments did not respect Red Cross armbands. Medics regularly exposed themselves to fire to reach wounded soldiers, dragged casualties to cover while under attack, and performed first aid while explosions erupted around them. The casualty rate among medics was tragically high, with some units losing multiple medics in single engagements. Beyond their medical skills, medics provided psychological support that proved almost as important as physical treatment. A wounded soldier, terrified and in pain, drew comfort from the medic's calm presence and confident care. The simple act of a medic talking reassuringly while treating injuries helped prevent panic and shock. Many soldiers later recalled that their medic's arrival, not the treatment itself, was when they first believed they might survive their wounds. The relationship between infantry soldiers and their unit medics was unique. Soldiers knew that if wounded, their medic would risk his life to save theirs. This created bonds of trust and affection that transcended normal military relations. Medics were universally respected, often beloved by men they served. The nickname Doc, applied to medics regardless of actual rank or education, reflected both affection and respect. Navy corpsmen serving with Marine Corps units faced particularly intense combat. The island-hopping campaign in the Pacific featured some of the war's most brutal fighting, with corpsmen treating wounded Marines under devastating fire. The battles for Tarawa, Iwo Jima, and Okinawa saw corpsmen perform extraordinary acts of heroism, with many receiving Navy Crosses, Silver Stars, and in some cases, Medals of Honor for their actions under fire.